So, you know, I'm not going to spend a ton of time on, on the things that a lot of you already know, kind of the facts about IBD and IBS. We'll go over this kind of briefly. IBD and IBS are two illnesses, of course, that can affect the gastrointestinal tract. They can cause abdominal pain and changes in bowel movements. Whoops. However, they're not the same disease. While there are many similarities, I think it is important to highlight the main differences. So IBD, inflammatory bowel disease, there's two sort of subtypes, Crohn's disease and ulcerative colitis, and they have involved chronic inflammation of the GI tract. Whereas IBS is a functional gastrointestinal disorder that causes things like abdominal pain and changes in bowel movements, but there's no inflammatory component. In IBD, the GI tract is damaged. In IBS, what I tend to say is you can do every test in the world, but all the tests are going to be normal. However, symptoms may be quite similar. A lot of with IBD, again, IBS, you have abdominal pain, diarrhea, urgency. You have those same symptoms in IBS. You typically do not have blood in the stool with IBS, although you can, especially if kids have, IBS with constipation and anal fissures. One of the hallmark symptoms that I always ask about in IBS is a feeling of incomplete evacuation. And that's kind of my buzzword for IBS. And it's a symptom that kind of drives everyone crazy because, one of the things that I ask about is going to the bathroom, and, parents will always chime in and say, oh, she's on the toilet for like an hour every morning. And when I hear that, it's not I'm not 100% certain it's IBS, but that's a big tip off, that feeling of incomplete evacuation. Either you go to the bathroom and you feel like you have to sit there for a long time and nothing comes out, or you leave the bathroom and then you have to run back in and go again. So this difference between IBD and IBS, I mean, this is what we do as pediatric gastroenterologists. We do it all day, every day. And it's almost like every patient and parent comes in to the office with GI symptoms, worried that they have Crohn's disease. And that's a big source of referrals is, does this patient have Crohn's disease? And it's our jobs to kind of figure it out. So I'm going to try to help lead you through how I approach these patients. So just like we all know, the most important step is to see the patient, and doing it over telehealth is fine. Even over the phone, we do a lot of phone consults when we're at Kaiser. Usually that's okay, but you have to take a good, thorough history. And a big part of that is connecting with the patients. And, so I kind of try to warm them up. I try to make the patients feel comfortable and connect with them, because I'm going to ask the hard questions. I'm going to want to know everything about their symptoms. I'm going to want to know about their pain. I'm going to want to know everything about their bowel movements. I'm going to ask them how often they go. I mean, it's embarrassing. I mean, I try to preserve their dignity, but it is important to know what their stools look like, how often they're going. Are they hard? Are they soft? Are they liquidy? How many times a day, right? Are they seeing blood? I'm going to want to know about their appetite, their diet. And then after I have all that, then the behavioral health hat of mine comes out, and I talk to them about, their emotions, stress, and anxiety. But, I think you really have to kind of get a patient comfortable before you delve into that. And a lot of times they will, or the parents will volunteer that. And I always kind of applaud them for their honesty, and because that does make my job a lot easier. When it comes to actually seeing patients in office, do you or do you not? I mean, the exam can be important. History is by far more important, but exam can be important. Certainly in younger patients, when I have kids that are preteen, a lot of times they'll downplay their symptoms, and they'll say they, oh no, they don't have any pain. But when I cram on them in the office and see them wincing, then I know, what I'm dealing with. seeing them in the office, you can document weight loss or weight gain. So if you see someone in the office and they're gaining weight really well, that may reassure you that less likely you have IBD. But if they have weight loss, again, that may serve as a red flag. So I have this quote, you look like Crohn's. And so that's the other thing, is that, a lot of times, you can walk into the office, you can see someone, and we all have that, you have that instinct that yeah, this kid's going to have IBD. I put that in quote in there because myself and my co-fellows, our mentor, who also, many of you probably remember Pua Hobson. So she went on to do a GI fellowship under my mentor, and he's a Hungarian guy with this thick accent. And there was an administrative assistant that worked in neurology, and she stopped us one day and said, "Oh, can I talk to you guys? I was diagnosed with celiac disease, and my adult gastroenterologist didn't really tell me anything about it." And we were like, "Look, we'll do you one better. We'll bring Dr. Horvath over. He's one of the world's experts in celiac. We'll bring him over this afternoon, and he can talk to you and answer questions." And he walked up to her, and we said, "Hey, Mary, this is Dr. Horvath. Dr. Horvath, this is Mary." And he extended his hand and said, "You look like celiac." And he didn't mean it to, but she did. I mean, she looked like she lost a lot of weight. She looked pale. She did. And so sometimes with Crohn's kids, I mean, that's it. They'll just kind of look like Crohn's, and so that may be an advantage of seeing them in the office. Now, in addition to seeing patients and getting a history, I used to say 90% of the time, history alone, I can tell you if you have Crohn's or if you have IBS. If you add in a CBC, a SED rate, a CRP, I would say 98% of the time. So I had one patient in the first 12 years of my career here that had a normal CBC, SED rate, and CRP and ended up having Crohn's. One. However, COVID has really changed everything. So I've had 6 patients in the past year that had normal CBC, SED rate, and CRP and ended up having Crohn's. I'll come back a little bit to COVID, but now we use a test called a fecal calprotectin, and so far, since we've been using this test, which for years we couldn't get insurance to cover, but now we can, neither Camilla or I have had anyone with a normal fecal calprotectin that ended up having Crohn's or ulcerative colitis. Okay, so moving through again with Crohn's, we've kind of talked, and IBS, we talked about the symptoms again, blood in the stool and weight loss, not typical for IBS, and that's a big difference. When we go to the diagnostics, so in IBD, anemia may be present, usually not in IBS. In IBD, stool calprotectin, in our experience, is always elevated. In IBS, it's not. Sometimes you'll get an intermediate and need, or a borderline result, and you may have to repeat it. And then again, on endoscopy, colonoscopy, you see inflammation, redness, swelling, ulceration, friability of the mucosa. You don't see that in IBS. Endoscopy, colonoscopy are normal. On imaging, if a kid happens to get a CT or MRI, you should see inflammation, where you won't, again, with IBS. Treatments, so I put this slide in, you can see, pretty directed treatments for IBD. For IBS, there's a ton of things that you can do. I'll talk about what I do later. So complications of both. For Crohn's, again, strictures, fistula, abscess, bowel obstruction. When you get older, there's an increased risk of colon cancer for UC, colon cancer and megacolon. These IBD kids are also at risk for malnutrition and anemia. For IBS, really, I mean, physically, not much. Chronic constipation, diarrhea, maybe leading to hemorrhoids is about it. But the big thing is the psychological impact of both of these, disorders, and that's usually the biggest thing. So, quick difference between Crohn's and ulcerative colitis. So the simplest way to think about it is ulcerative colitis only affects the colon. Crohn's can affect any part of the GI tract. The inflammation in ulcerative colitis is continuous, whereas in Crohn's, you can have what we call skip lesions. So you have an area of inflammation followed by a, a normal appearing mucosa, and then another area of inflammation. With Crohn's, symptoms are much more kind of variable. We see a lot more weight loss and growth failure in Crohn's than in UC. In UC, we almost always see blood in the stool. Where in Crohn's, again, that can be variable. And in Crohn's, the growth failure may precede the GI symptoms. So, gastroenterologists, when we see kids, either not growing, not gaining weight well, or even with delayed puberty, that's what we think. We think Crohn's. So these slides, these next couple of slides, I apologize for. I queried IT to see if I could get all the data on my patients and Camilla's patients since I started here, and so I could have all the IBD patients, and so we could see trends and see how many we're seeing in all the IBS patients. But I asked them, close to 6 weeks ago, but they haven't gotten back to me, and so I got an email saying, oh, there's this thing Slicer Dicer, which I never used, to try to pull things myself, and I don't really know how to use it. So I tried, and so, but it kind of looks nice, but so this slide is IBD. That's why I bolded it. Green is Crohn's and orange is UC. And so part of what I want, and it looks like this. Okay, it looks pretty whatever. But there's a couple things that I have to say about this. So when I search for Crohn's disease, I search for Crohn's disease, without complication. That's what the green is. If I search for Crohn's disease with blood and stool, it's another bar. And so there's 20 different Crohn's things, and I couldn't figure out how to get them all in one bar. It was like 20 bars, and it was really messy. So I was just like, well, let me just make a slide and just talk you guys through what this means. So I just did Crohn's disease without complication and ulcerative colitis without complication, just to simplify the slide. And so that is the number of patients we're seeing, like that we have been seeing, I guess, with that diagnosis, right? And this is just my patients. It doesn't include Kaiser. And so Camilla, you joined in what year? 2018? What year did you join? 2017. Okay. So one other thing to see is, okay, if you look here, like 2016, 2017, this is when Camilla joined me. So her patients aren't here. So that's why you see this downtrend probably in my patients, because she was seeing more. But even if you don't look at, and also we started going to Kaiser. We would still see Kaiser patients, but we do more procedures, see more at Kaiser as well, with both of us there. But one thing to see is that if we look from 2019 into 2020, as we have this jump in Crohn's patients. And so on a given year, new diagnosis of inflammatory bowel disease, I usually would say I would diagnose 6 to 8 patients per year. In 2021, I diagnosed 22 patients with Crohn's. So almost, 3 times as many as a typical year. And then Camilla, another 11. So going from 6 to 8 to 33 IBD patients in 1 year, huge difference, right? Huge jump. Why? It's got to be COVID related, right? One of the hypotheses of IBD is this hygiene hypothesis. Countries that are too clean have higher rates of IBD. We were super clean for a year, then kids are getting exposed. And so perhaps, that's led to the jump in more common IBD diagnoses. What about IBS? Well, again, if we think about the same thing, you see that downtrend in numbers going up, going up, going up, and then this downtrend. But again, if you double that, right, I think that you're just going to see this uptrend in IBS cases would have continued if we added Camilla's patients here, if we added Kaiser patients. So I used to say I see about one new IBS patient per day, maybe every other day. Now we see at least one per day, every day. Sometimes maybe even up to 2 a day. Okay, so IBD and IBS. So the times have changed, but they also haven't. So when I was a fellow, I remember meeting one of the attendings, and he would say, he said, I wouldn't wish Crohn's disease on my worst enemy. And our nurse practitioner used to talk to patients about Crohn's and say, well, this is going to be a rough first year. You're probably going to be in the hospital 2 or 3 times. You're going to need to be on steroids for probably half the year. The second year, you'll probably only get admitted maybe once, maybe twice. You'll be on steroids for maybe 3 months. And then by the third year, there's a good chance you won't be hospitalized. You may only need steroids a few times. And I used to think, that's acceptable? Like, but we weren't using these newer medications, biologics. We were using them as a last resort. So when I came to Hawaii, the first patient I diagnosed with IBD got admitted. And I started her on infliximab, which is a TNF alpha inhibitor, you probably know it as Remicade, right away. And she did phenomenal. And so the next patient that I saw, the next few, I couldn't get insurance to cover it. Finally, a fourth patient, I wanted to start on infliximab, and the kid was not doing, had pretty bad disease. And I happened to talk to, the medical director of one of the insurance plans and said, let me try it on this kid. And I tried it and it worked great. And I gave him feedback and said, yeah, look. And so he agreed to say yes to another patient, and then another patient, and then I just went from it. So I really started to treat kids very early and very aggressively with biologics before most people who weren't doing pediatric studies. And that's been a huge benefit to my patients. Using drug levels and antibody testing has also helped to tailor therapy. And then for me, I've really taken pride in personalizing my IBD treatment plans, as opposed to a lot of people who use standard dosing regimens and doses and regimens for these drugs. I like to kind of personalize my care, and I think that's been very rewarding for me and for my patients. We also used to tell patients that you'll be on medications for the rest of your life when you have Crohn's disease. I have 6 patients that are now young adults that I've kind of stayed in touch with that are off all drugs, in remission, endoscopic remission even, and doing well. So I don't tell patients what we used to tell everybody. But what doesn't change? Well, there's still very few studies that show any drugs are superior to placebo in IBS, but that doesn't mean I don't try them, which I'll get to. But there are more and more studies showing the benefits of cognitive behavioral therapy in patients with IBS. So what do I do when I get a new consult for abdominal pain? Well, first thing I do is I go into your notes. I review EPIC. I read through the notes. I read ER notes. I look at labs. I look at imaging, growth chart. Most of the time, I have a pretty good idea what the diagnosis is going to be. Then I see my patient, take a thorough history. If I think you have IBD, right, like I said, if your labs are abnormal, your fecal calprotectin is abnormal, or I just have that feeling you have IBD, I just go straight to EGD colonoscopy. And I just tell patients that's it. There's no way around it. That's what you're getting, because I'm worried about you. If they haven't had those studies, CBC, CMP, SED rate, CRP, fecal calprotectin, I'll do them as a baseline, just so I have it for something to track and as we start management. If I suspect IBS, then we have a discussion about how we're gonna come to our diagnosis, and I'll get to that later. So if I think you have Crohn's, I scope you. And if I confirm it, so this is my approach. So first line, I use either a biologic, infliximab, or now Inflectra, which is called a biosimilar, which is meaning it's almost the identical molecule. It's just made in a lab instead of, it's synthetic rather than using mouse antibodies. Or I give adalimumab, which is Humira, which is, and the main difference, these medicines work equally effective in my opinion, but the main difference is drug delivery system. So one's IV and one's sub-Q. Now, if you get Inflectra, you get it IV on day 1, day 14, 6 weeks after that, and then every 8 weeks is standard. But again, I personalize it. If kids aren't doing well, they may get that 3rd dose and 4th dose at shorter intervals. An advantage is changing the dose, because it's an IV and we weight base it. Dose escalation is easy. Changing the interval is easy. The difference with Humira is it comes in a fixed dose. So it comes in 40 or 80 milligram vials. So you get a loading dose of 2 of 160, then your second dose is 80, and then, which is 2 weeks later, and then 2 weeks after that, you get 40 milligrams every 14 days. So if you want to go up, if they're not doing well, then your only option is either to move their shot up and give it every 7 days, or increase their dose to 80. There's just no in between, right? And so you might be over treating, by a lot, because you may not need all that drug. So a little harder in patients that aren't doing great to adjust the dose. We do use drug levels also to help tailor where we're at. An advantage of Humira, though, is it's done at home and you don't have to come to the hospital. And it's an injection, right? It's quick. The downside to Inflectra is that it's an IV infusion. So most kids come to the PAL unit, and maybe rather so go to the hospital or infusion centers. And it takes a couple hours. They have to miss school. But we are doing some home infusion. So there's an infusion company that'll come to your house and give it at home. So some patients are taking advantage of that. The other real difference is, if I have a patient with a fistula, I'll almost universally use Inflectra, because to close fistulas sometimes requires really high doses. So standard dose is 5 milligrams per kilogram. They may require 3 times as much to get that fistula closed. If I can get away with just the biologics, that's what I do. I try to not use steroids, but some people need them, and steroids are powerful anti-inflammatory agents. So I will sometimes use steroids for that. In patients if I diagnose them with ulcerative colitis, if they have very mild ulcerative colitis, then I differentiate mild versus moderate to severe. So very mild disease, I may try to get away with a topical drug like a mesalamine. You avoid immunosuppression. There's single dose formulations where you take it once a day, and that really helps with compliance. Rectal formulations can be very effective for kids with distal disease. Kids almost never want to take them this way, but they are incredibly effective because you're getting the drug right to the source, right to the area of inflammation. So usually start with the mesalamine. If that fails, then in mild disease, then a second line is budesonide, and it's the MMX is this, again, it's a matrix system, so it's a single dose formulation. You take it once a day. It tends to work pretty well. It has a very high first pass effect, so you don't get a lot of systemic side effects, although some patients will report it kind of makes them moody. Again, it doesn't have immunosuppressive effects. So that's what I do with mild UC, and we can usually get away with it. If you have moderate to more severe ulcerative colitis, I go with biologics. A difference with UC is that a fair number of patients will have what I call a protein losing colopathy. So their albumin will be super low. It'll be 2, it'll be 1.8. Those kids may require high doses because the drug binds to albumin. So that's something that I kind of look at. With Humira or adalimumab, the dosing schedule is higher than Crohn's. So Crohn's is 160, 80, 40, and then 40 there on out. Where with UC recently, within the past 6 months, the dosing was changed to 160, 80, 80. Sometimes I will add on that other drug, mesalamine or budesonide MMX, in kids that aren't responding perfectly. And I want all my IBD patients to be doing perfect. And so again, if I use steroids in more severe cases, I still try to wean them as quickly as possible. Okay, so if I'm in the office still, I don't think you need to be scoped, and I think you have IBS. How do I approach it? Well, I probably spend more time selling this diagnosis than any other that I have to make. A lot of times I'll say to patients, what brings you in to see me? And they'll say, and I hear this from a lot of parents too, I've been to so many doctors and nobody can tell me what's wrong. And so I say to them, I can tell you exactly what's wrong. This is what's wrong with you. And I think it's very important with functional disorders to make the diagnosis and stay firm and don't waver. Because, if you're confident in the diagnosis, be confident and make that patient and that parent understand that, you don't need more tests, or that this is the diagnosis. And if you can do that, you can sell it. They accept the diagnosis. You're the first person who's ever told them what's wrong. Hey, a lot of times they're happy. Let's go for that. And so, okay, how do we treat it? And so that's always the goal, is that you get them to accept the diagnosis, and then you tell them, this is how we're going to get you better. But sometimes that's not enough. Sometimes parents want reassurance. And so if they want reassurance, I kind of give them options. Okay, conservative approach is we just treat you because I'm confident in your diagnosis. But if you need more reassurance, then I'll do those labs, right? CBC, CMP, sed rates, CRP, celiac. I usually throw in a celiac panel and a lipase as well if I'm doing labs, and then that fecal calprotectin stool test, right? And I, again, that provide, use that to provide reassurance, right? But some people say, I just need to know. I can't sleep at night unless I know 100% sure my kid doesn't have Crohn's. And so, I will say, okay, well, let's do an endoscopy and a colonoscopy. Now, why do I do this? So again, if I go back to my fellowship, I remember seeing a patient with my fellowship director, and I said, I think the patient has irritable bowel syndrome. And he said, and I said, so I think I want to try this and these changes, and I'll get to. And he said, well, IBS is a diagnosis of exclusion, so they need an endoscopy and a colonoscopy. And I said, oh, okay. Okay, well, let's go talk to them about that. I didn't know that. And so then a week later, I'm in clinic with a different attending, and I say, I think it's IBS, but IBS is a diagnosis of exclusion. And so we need to do an endoscopy and colonoscopy. And she said, IBS is not a diagnosis of exclusion. Read a book. There's a Rome criteria, which defines it. You just need to take a history. If you think it's IBS, you don't need to do any tests. You just need to be firm on your diagnosis. And so, but so why do I offer it? Well, why I offer it is because, like I said, I really want to personalize my care. When I was a fellow, when I saw a patient who said, well, it's diagnosis of exclusion, we need to do an endoscopy and a colonoscopy, some people would say, well, I don't want to do that. And the attending would say, well, that's what we have to do. And then what would happen? Well, the patient wouldn't follow up with us, and they would go see another doctor across town, where they would say, you don't need a scope test. Or if somebody said, I really want my kid to have an endoscopy and colonoscopy because I'm worried, and I say, you don't need it, you have IBS. And parents will go, okay, well, I'm going to go see somebody else. So, I'd rather be the one holding the scope. I mean, I'm confident in my procedure skills. I want to take care of that patient. So I'd rather keep them in my care, do the procedure if that's what they really want, because again, I want to take care of this patient. I want to get them better. I want to see it through. And so that's just how I started my practice and how I've continued it. So when I make that IBS diagnosis, however I get to it, and usually in the first visit, even if we're going to do some testing, I talk about, I think you have IBS. And what are the driving forces for IBS? The first is diet. The second is the bugs in your gut or your microbiome. And the third is emotions. And so, you know, I kind of open by talking about the first two. So, and you know, when I start that way, a lot of what I'm doing is, you know, trying to get them to eat healthier and talking about how that can trigger symptoms, and see if they chime in. Oh yeah, when I have too much of this, yeah, I noticed that too. When I talk about the microbiome, you know, a lot of it is kind of sciencey, and you know, depending on your audience, they sometimes, you know, they kind of like that you're staying pretty current with that. And then, you know, then I kind of get into the emotions. And again, it really, I do feel that a huge key is kind of making that connection. So again, so sometimes parents just, they want data and they want, I'll give them that. But a lot of times I'll make it personal and try to connect with kids that way. And so, you know, one of the things that actually, you know, kind of hit me is I used to say, I know what stresses kids out, you know, school, their future, parents, siblings, you know, extracurricular things like sports and clubs and things. But then, you know, we had this meeting a few years ago where they were talking about changing the HPH website, and that patients were going to be able to go on and they were going to like be able to read about us, and after their visit, they're going to be able to like rate us with a star system. And a lot of us were kind of grumbling, like, I don't know, I want that. Like, I don't want to be treated like, you know, Yelp. And, you know, if I get a 3-star rating from somebody, I'm not going to sleep for a week. I can tell you that right now. And so, okay, so I had this meeting on my mind when I flew to Chicago for our national PHGI meeting. And then I, you know, of course, time change, and I get off the plane and I open my phone, and you know, I have an email from United Airlines saying, how was your flight? And then I got in an Uber and I went to, you know, my hotel, and I got out of the car and my phone beeped and it said, how was your ride? And then that night, you know, I went to dinner. My brother came to meet me in Chicago and with some of my co-fellows. And after I got back to the hotel, I got an email from the restaurant saying, how was your meal? We love to be reviewed on Yelp, right? And I thought, you know, this is the world, and that this generation, this younger generation, is a generation of raters and judgers. But in turn, they're probably always feeling rated and judged. And so I talk to my patients about this, and I just get nods, you know, they get it, you know, they see where I'm coming from, and I kind of understand that. And that often kind of helps open me up a little bit, open them up to me a little bit about their own experiences. Okay, so what do I say about diet? I stay basic. So one is I talk about a low FODMAP diet. I basically say avoid processed foods, avoid things in boxes and bags, avoid fast food, juice, soda, all the things that are delicious. I talk about how, you know, I look at the big food corporations as public enemy number one. I mean, they've found a way to create these addicting, delicious foods that are cheap and convenient, and it makes it really hard to be a parent, you know, because they have billions of dollars to spend on this stuff. So I talk about that, but I don't harp on it. I don't lecture the kids. They don't want to hear that. But then I give them resources and handouts that they can look at when they get home, and parents can go through. I talk about a high fiber diet. Again, I say stay basic, fruits and vegetables, eat real food, not processed food. I tell them fiber supplements are okay, but as you know, what I used to always say is one of the things that happens in Hawaii is that, you know, every once in a while, everybody on fiber supplements, like the cargo ship that's bringing those supplements here doesn't make it, and then everybody gets constipated. And now with all these, you know, these problems we're having with you know, shipping, I think probably we're going to see that more and more. So, and again, but I provide handouts and resources for more details. But I talk about the microbiome, and I like to talk about this stuff, and I think it just depends on on my audience. There's more data. It's growing evidence for the microbiome. Um, you know, I go back to when I was a fellow, and I once, after I was in London doing liver transplant hepatology for a month, and saw the gastroenterologist there, recommending probiotics, I came back and wrote in a chart to try a probiotic for this post-infectious diarrhea. And my chief of gastroenterology told me to tear the consult up and never write probiotics on a chart again as long as I am working there. And I remind him of this every time I see him. But there is some growing data on probiotics. I do use them. There is also a new test for IBS with diarrhea. I haven't used it yet, but it's supposed to be pretty reliable if you really needed something and parents that weren't afraid to pay out of pocket for some confirmatory stuff. But so probiotics I mostly use Bifidobacter and Lactobacillus, but I'll use combination. I like to use single agent probiotics myself, but a lot of times multi-bug formulations are cheaper. I have a lot more success in IBS with constipation with probiotics compared to IBS with diarrhea. It often makes diarrhea worse. I'll still sometimes try it. As far as antibiotics, it's what everyone on the mainland is diagnosed with. So if you guys remember Sarah, she is now a pediatric gastroenterology fellow at Yale. She wanted to do GI. And I said, if you do, I think you should do a rotation on the mainland because you'll have a much different experience than you will here. And so she came back from, I think, UCLA. And I said, how is your rotation? And she said, everybody gets diagnosed with SIBO, small intestinal bacterial overgrowth, and they give them antibiotics. No one ever gets diagnosed with IBS because people in California, I guess, don't want to hear that their kid has IBS. So everybody has SIBO. And I was like, it's true. I mean, people don't want to, they don't want to accept IBS, but they're happy to accept SIBO. So I will treat it at times. Again, I try to individualize it. I don't want to lose patients. I don't want to lose terms. Sometimes it's helpful. I find it most helpful in kids that are gassy or bloated or have really noisy stomachs. So I have this subset of patients with really noisy stomachs that they're embarrassed to go to school because their stomach makes so much noise. And I do have some success using antibiotics in that patient population. And it's safe. But I think I use it much more sparingly than most pediatric gastroenterologists. And then the big one, right? Emotions, stress, anxiety. And again, you have to ask the hard questions. You have to kind of be the bad guy. And you do really have to sell the referral. And I tell patients, yeah, therapy hurts. I tell them, if you break your arm and you're in a cast like this for 2 months, and then you want to go back to throwing, you're going to go to therapy, and they're going to stretch you and strengthen you, and it's going to hurt, and they're going to torture you for an hour. And then they're going to end the session and say, come back and see me next week so I can torture you more. And then they're going to say, oh, by the way, here's your home exercise program because I want you to torture yourself every night before you come back and see me. But therapy's the same for your mental health. You have to work at it. It's going to be hard, but just like physical therapy, you can get back to pitching, you can get back in the game, you can get back to school, you can get back to life. And that's my goal. I use the word mindfulness more than any word I use in my practice. I talk a lot about mindfulness, and I spend a lot of time talking to my patient about it. I get personal. I pull up, my phone, and I pull up the Calm app that my wife and I listen to every single night before we go to bed, because mindfulness works for us, right? Now, I do have an advantage because I do a functional gastrointestinal disorder clinic with Sherry, nurse practitioner from behavioral health, which has been a game changer for me. So I can say to patients, look, you know, she's amazing. She's one of my favorite people on planet Earth. I trust her. She's helped so many kids. She connects well. You know, and if patients, if I've connected with them and they believe in me, they know I'm going to put them in the hands of somebody who helps them. Or I say, look, we have clinic next week. Why don't you come back? Or why don't we do a telehealth visit with her? You can meet her that way and, you know, see what she's all about. And it's kind of like I always say, in my philosophy before, you know, I always wanted to have that somebody with me, because I say it's like if a friend of yours, like an acquaintance, let's say, sends you a text message and says, hey, we should get together for coffee today after work. If you don't really want to do that, it's pretty easy to go, sorry, I have plans. But if they're right in front of you, it's a lot harder to say no, right? And that's what I have. I get Sherry in the room with them. They get to know her, they get comfortable. She tells them about what they do, and she says, what do you think about coming back to see me next week? Everybody says yes. So that is an advantage I have. I think telehealth has really helped as well, because it's just more comfortable. You do it from home, you know. I think there's comfort in that little red hang up button that, you know, kids can hit if they really aren't, it's not going well. And so that's, I think, the kind of things that have changed for me and have been helpful for me. All right, as far as medicines, again, the key with IBS, just like I said, even though there's not a lot of science, I think I still do use medications for IBS. I sell it, you know. I say, yeah, nothing you've tried worked, but you haven't tried this yet. So I treat the different subtypes differently. So with IBS, with constipation, I may try probiotics. People like that, maybe fiber supplements. If they're constipated, stool softeners, I use a lot of polyethylene glycol, Miralax. If patients don't want to do that, lactulose, Colase, and some of the newer agents which aren't approved for kids. So, but sometimes with older teens, I can get them approved. I will use some laxatives, but I don't use a ton. With IBS, and you could certainly, anybody could do these things to try to help minimize your patient's symptoms. And that's what we're looking for, minimizing symptoms, you know, because again, you get them to start feeling better. And then eventually a big part of it is getting them into IBS. I mean, getting them into behavioral health. With IBS with diarrhea or mixed alternating constipation and diarrhea, I use a lot of bentyl dicyclamine. So it's an antispasmodic or an anti-cramping medicine. So it's probably the most common medicine I prescribe. It's used on an as needed basis. You can use it every 6 hours as needed, but I would say the majority of my patients, probably, I just have them take it every day. So, you know, because they can use it to prophylactically to prevent pain. And again, whether it's placebo effect or not, my goal is to get kids to school. Because if I can get them to school, most of my patients with IBS, they're stressed, they're, you know, and they're anxious, and they're also good students. And so when they get to school, they're mindful. So I just have to get, and they don't have a lot of symptoms at school. So the key is trying to get them there. So I tell my patients, in the morning when your alarm goes off or your mom wakes you up, I want you to sit straight up. Don't hit the snooze button. If you snooze, you're going to lay there, you're going to think. I don't want you thinking. You sit straight up, you take your medicine, and you start getting ready for school, and you do not stop moving until you're in the car, on the bus, at school. And that most kids, then they're fine. But it's just getting them there. And again, if you can do that, the impact it has on kids psychologically or on their lives or their parents' lives is enormous. For kids with diarrhea, a lot of times I'll tell them take loperamide or Imodium, either in the morning before school or in the evening, even before they go to bed, basically just to prevent them from having diarrhea, because kids won't go to school with IBS because they don't want to go to the bathroom at school, or they don't want to go to the bathroom, you know, 3 times in a day at school and have everybody go, why are you in the bathroom all the time? So, you know, there is a lot of people have reluctance using loperamide. I think, you know, in infectious diarrhea, you know, I learned that too, but I have zero reservation about having kids take loperamide every single day if they have IBS with diarrhea. So if you have patients who they don't want to go with the medicine route, so a lot of people, they'll say, I want to avoid medicines. I want to do things naturally. There's two products out there. They're not FDA approved, but they're kind of, one, iberogast is kind of an herbal blend. One of the herbs is peppermint. So these are safe, natural alternatives. I've actually had some fairly good success with both of these. IB Guard is peppermint oil, and there's some good studies showing the benefit of peppermint oil in functional disorders. So these are natural things, safe things that I can try if my first line drugs that I mentioned fail, or if patients don't want to use medications and want to do something natural, but they still are willing to do something. So the future, I mean, there's always new drugs and new drug delivery systems coming out. I get asked a lot about fecal transplant. I mean, I do think there may be a role in the future. We're just not there yet. And then, future, epigenetic stuff, I think a lot of people are going to be excited about for the future. So takeaways, most importantly, see your patient, take a good thorough history. Most of the time, that's all you're going to need. If you suspect IBD or you want to reassure, do those tests. If you're going to refer a patient to us, it's really helpful for us if we have those tests because already completed, because then it kind of may save us that step where now we have two options. Do you want scope, or or do you want to just believe in the diagnosis? I try to make it personal every step of the way. So it's some kids hate needles, and you're not going to get them to agree to blood tests. That's where the stool test can be handy, just doing that. But you have no idea the number of kids who would do anything. They'll say, I'll do a colonoscopy. I don't care. I will not poop in a cup. They just won't. And so, okay, so hey, that's a kid who maybe does labs or we scope. I try to personalize everything as we move forward and follow-up visits. Again, I try to personalize their diet. What are you eating? How are you eating? And make tweaks with that and suggestions with that, changing the medications and supplements. We make those decisions together. But again, you got to sell it. You got to believe in it. And especially with the importance of behavioral health. And then I think if we're ready, maybe, I don't know, we can move on to questions.
Thank you so much. That was so straightforward, and I think gives us some really good pointers for like how to get started with addressing these problems of abdominal pain, constipation, and diarrhea that come in so frequently. So thank you so much for that, Jeremy. There was one question in the chat to start, and then everyone else, please feel free to unmute yourself or drop your questions in the chat. We have about 3-4 more minutes. Dr. Ware is wondering, what's the cost of Inflectra, or for that matter, infliximab versus adalimumab?
So infliximab, I mean, roughly, so we weight-based everything. So it depends on, bigger kids are going to cost a lot more. It used to be about $1,000 a vial per 100 milligrams. And so interestingly, today, I had a patient who's downstairs getting his infusion, and his weight-based calculation came to 201 milligrams. So I've worked out a deal with the pharmacists, with Christy. If you're under 20% above your opening a new vial, so for this patient, if he was 219 or less, down to 200, we wouldn't open a new vial. Above, we will, just to save that cost. So she messaged me like, his is 201, can I round down to 200? So we'll round down when we can to save money. The other thing is that I've primarily switched my patients all over to Inflectra. So Inflectra is a biosimilar, and it's 1/43 the cost of infliximab. So it is enormously cheaper, and that's why I've transitioned my patients. Humira I don't know the cost. I would say I think it's less, or adalimumab. I think it's less expensive. I'm almost certain than infliximab, but it is still fairly expensive.
Thank you. I'm curious what you think might have caused the remission or possible cure in your IBD patients who received biologics that you mentioned in passing earlier on.
So I think there's a very good study that came out that it was an adult study, and it showed a graph basically which had, you know, inflammation on the x-axis and time on the y-axis, and then in addition on the x-axis was risk of long-term complication, mainly stricturing, fistula, and a need for surgery. And it was very clear that if you control the inflammation early, the risk of complication 3 to 5 years out was really low compared to patients that you didn't control the inflammation. And if you kind of remember back when I was talking about our nurse practitioner, Millie, telling patients, oh, the first year is going to be really bad, the second year, those kids they did poorly. They had a lot of inflammation for 3 years. And probably why they started to do better is after 3 or 4 years, the disease kind of starts to burn itself out. And but then they're at risk of complications, but the inflammation kind of burns itself out. So with my being very aggressive and treating early with biologics and getting kids into remission right away, whenever I can, I think, you know, controlled the disease. So that first patient that I put on Remicade, the first patient I diagnosed here, right? She's been off of medication since she was 18. She's like 26, 25 now. But she did great from the beginning, and we eventually just started weaning down and weaning her off of medication and weaned off altogether. And the same with other kids. We treat them aggressively at the start, get them in remission when they're 12 or 13. And then, you know, when they're 18, you know, they go away to college and they say, oh, they come back and say, I forgot to take my medicine for, you know, 3 months and I'm fine. And that's kind of how it's been.
That's really amazing. I didn't actually know that was possible. So that's something really nice to just kind of relay hope to our patients when they're feeling so junk when they come in.
Yeah, and it really is just really I only learned it because of that first patient whose parents convinced me, can we try to wean? She's been doing so good for years. Let's go to a lower, what we would consider a sub-therapeutic dose. And we kept going down and down. And, you know, I remember, you know, them saying, can we stop it altogether? And I emailed a colleague of mine named Marla Dubinsky, who in the pediatric GI world, like if there's a pediatric IBD study, she's involved. She's like the guru. And I emailed her and said, hey, I have this patient. They're on 2 milligrams per kilogram of infliximab every 12 weeks, which is half the dose and 4 weeks longer of an interval. The parents really want to stop it. And I still have the email she replied to me. She wrote back 2 words, they're dreaming, meaning don't stop it. Well, I did. And she still, well, pre-pandemic, this patient takes my daughter horseback riding every year for her birthday. So
that's a nice way to close. Thank you so much for sharing that story. Any last questions before we go? We're a couple minutes after 1 o'clock. I don't see anything popping up in the chat, so we'll just say thank you so much to Jeremy King for sharing this great presentation, and thank you to all of our participants for joining us.